So welcome to this session of faculty talks on iconic retina talks. And I have with me none else than Natarajan here and Manoj Sasode. We'll try to make this session as informative and interesting as possible. And we have,
We have Jasmeet there.
yeah, sorry, Jasmeet
As a co-convener.
as the co-convener, and Srinivas also may join because I saw him outside. So this session has, you see, couple of talks on ROP. Then we have PCV by Dr. J. Then myopic foveoschisis, and then GRT tips of management and RD with PVR. So I'll request first of all Dr. Simar Singh to begin his talk. He will tell us about anti-VEGF agents in ROP. You see, ROP has long been treated only with lasers. So for last couple of years, in fact, more than that, people have started. In fact, now these anti-VEGF agents have been approved, by FDA also for usage in ROP. So let's hear from Simar about the pearls and pits about ROP anti-VEGF usage. Yes, Simar.
Can I have my talk, please?
Can we have silence here? People who want to talk only, they can move out, in fact, if you want. Yes, Simar.
Good afternoon, everybody, and thanks to AOS for this opportunity here. So I'll be talking about anti-VEGF injections for ROP, the pearls and pitfalls. So anti-VEGF agents are now being increasingly used in treatment of ROP thanks to these two landmark trials that beat ROP and the Rainbow study, which showed us that for the first time that yes, ROP can regress, vessels can form more than what they were without treating with laser treatment. So yes, obviously people were very excited, and now it is kind of being used as the mainstay of treatment at many places. So I'll just be talking about a few pearls and pitfalls that this approach might have. So the pearls, first, for the giving the injection, the technique that is to be followed for giving the injection in these small babies. So we have to understand that infants are not smaller adults. The eyes are not just smaller in size, they are different anatomically also. So the eyeball is short, yes, the eyeball is about an average of 16 millimeters at the time when we are injecting the child. But the crystalline lens is very thick. It takes up a lot more space in the vitreous cavity than what it would do in an adult. So we have to be careful while going inside the eye. We are more likely to hit the crystalline lens. The pars plana is poorly developed, so we are primarily going to be going in from the pars plicata. So we have to be careful of the distance we are measuring from the limbus to go inside the eye. And the retina could be lifted in some of these eyes, so while entering, the length of the needle and how much we insert the needle could be important, so as not to hit that lifted retina. So where to enter, it's a range that has been shown in various studies, but on an average at the time of 34 to 36 weeks PMA that we are injecting, 1 millimeter is usually a good distance to go inside the eye. You can use transillumination, you want to be more sure about that distance. How to enter is very important. So normally we are trained to aim our needle towards the center of the optic disc. However, in these small children, because the lens takes up a lot more part in the vitreous cavity, you want to be parallel to the visual axis and go straight in so that you don't injure the crystalline lens. Which needle to use is another debate. So 12.7 millimeters 30 gauge needle is what we most commonly use. An insulin syringe has a 8 millimeter needle. Both have the potential to hit the retina on the opposite side if taken fully in. So 4 millimeter needle is what is being recommended nowadays, though the availability of the same is still an issue. What dose to inject? So these are the three main anti-VEGF that we have had experience with: ranibizumab, bevacizumab, and aflibercept in ROP eyes. As a common thing, half dose is what is most commonly used because we don't have doses that are allocated specifically for these small babies. So half dose can be easily made from the volumes that we have, but people have shown effect with even 1/16 or 1/32 of the dose that we are injecting in adults. So for India, ranibizumab and all over the world, this is one drug which has FDA as well as DCGI approval. Just a point about the approval, the pre-filled syringe is not approved in India. It is the vial that is approved in India, because from that 0.2 milligrams can be extracted out for injecting. You could inject it anywhere, even in the NICU, in a sterile environment, in your OR and under topical, or in some of the bigger babies under general anesthesia. All you have to do is maintain a sterile field. You should have sets ready for both the eyes, because in the majority of these children we would be injecting both eyes at the same time. So you should have equipment ready for that. And sterile field is most important. I like to drape both the eyes together at the same time, change my gloves in between the two eyes, and then inject the other eye. And I'll just show a small video of the procedure being done. So you put up the speculum in one eye, I put the speculums in both the eyes in one go, so that my gloves are not again and again touching the field. And then the injection, you can see the direction of the needle. This is more vertical than what we would give in adults. Then it's just a small procedure and ended with a drop of betadine and antibiotic. And then you repeat the procedure in the other eye, and then take out the speculum and patch both the eyes with some ointment and antibiotic. The same procedure gets repeated in the other eye. After injection, it is very important to always examine the next day. Look for any drop in media clarity, any signs of lenticular touch. Look for reduction in the plus disease. You can usually see the reduction the very next day. And it is preferable to give topical antibiotics for maybe a week after the injection. Now here is when the main thing of the perils of anti-VEGF start. Giving the injection is very easy, probably easier than what laser would be. But the problems start over here. So local procedure related complications could be cataract, endophthalmitis, hemorrhage, or sometimes even retinal break directly from the needle. Local recurrences are something that we are most troubled about. The recurrence of the disease is very uncertain, and it comes in a majority of the cases. Worsening of traction is also a part of the recurrence, and also the long-term neurodevelopmental effects, which we still don't have a clarity about. So this is one patient who presented to us with cataract following the anti-VEGF injection, and you can see this needle track, the injection being given directly into the lens, and the hydrodelineation-like effect created in the crystalline lens. So you have to be very, very careful about the direction of your needle. Endophthalmitis, because it is an invasive procedure, is another problem. So you have to be careful about the asepsis of the procedure, and especially you are going to be injecting both eyes at the same time. So it has to be very, very carefully monitored, and proper consent should be taken regarding the same. Hemorrhages we see quite often, sometimes even following laser, because there are pressure changes in the eye that are happening, and these vessels are very fragile at the time that we are injecting them. So yes, while after giving the injection, there could be some amount of bleeding from these vessels, and the patient should be counseled accordingly. This was a very unique case where we had a retinal break post-injection and was referred to us. It could be because of a direct jet stream injury. It could be because of directly the needle hitting the opposite side. But again, another important peril that can happen because of the procedure-related complications. The most important part is the recurrences. So, and especially in zone 1 disease, we would see them in almost 70 to 80% of the cases. So our job is not done once we have given the injection. Ideally, you would want to follow up these children every 2 weeks till the point there is a recurrence, and then treat that recurrence appropriately, likely with laser at that point of time. Or you would want to take this baby to about 55 to 60 weeks of post-menstrual age, and then treat that baby at that time under general anesthesia, do a fluorescent angiogram, document the area of avascularity, and treat accordingly. Because in a lot of these babies we see, even when clinically the recurrence is not seen, on angiogram you would see leakage and sometimes subtle neovascularization also. This is a case of a very frank recurrence that occurred at 6 weeks and treated subsequently with laser in this case. Another problem is, because the follow-up becomes so important, if the child is lost to follow-up, there is a problem. So this baby got lost to follow-up due to COVID lockdowns at that point, presented back with tractional retinal detachment in both the eyes. And once this proliferation develops in eyes having given anti-VEGF, it is very tenacious, very difficult to treat in these. Even with surgery, they have a poor prognosis. So this is a safer algorithm that has been proposed by the says that use a shorter needle, use proper asepsis, antibiotic and antiseptic. Follow up is the most important, 2 to 7 days post injection till the time you are going to see the child. Extra attention to detail, so clean environment, look for conjunctivitis, use of betadine, determine the location that you are going to give the injection, and recheck. Obviously follow up these patients every 1 to 2 weeks till the point you have a recurrence, and then treat that recurrence. Only then your treatment is complete. Just giving the injection does not complete your treatment. So to conclude, anti-VEGFs for ROP are here to stay. They are not the final answer for ROP, but they are an important addition to our armamentarium, and appropriate consideration to anatomy and technique should be given while administering these injections, and post-term, long-term follow-up is of utmost importance in these babies. Thank you.
Endophthalmitis.
Yes, sir.
And you said special consent should be taken.
Yes.
And you also insisted bilateral simultaneous injection. So that is my concern. And because you said you drape both the eyes together, so my concern is only this: first parallel endophthalmitis, special consent. Who on the earth parent will say कि दोनों आँख में इकट्ठा लगा?
So the disease is usually so severe that both the eyes require treatment urgently. You would want to
Anybody
treat
who's
them, it is
using,
convenient.
I would like to, because I personally am scared. Honestly speaking, I'm scared.
We are elocuting from the same vial. We are using ranibizumab only. So we are elocuting from the same vial. Yes.
So Vishal, you will get bilateral. Any? Denied? You give bilateral. Same vial. Refilled injection. We are also giving bilateral. Yeah. No, bilateral has a lot of advantages, no doubt about it. But you see, one end of one eye loss means I will never in my life give bilateral. Because this child, you see, who's potentially has to live for 80 years. Whatever. You see, how much do you lose by, giving a day or two apart?
Yes, sir.
What do you lose by giving day or two day apart?
I didn't get you.
No, why do you give, can you give 1 day, 2 day gap? What's the problem?
So for especially for the babies, there are logistical issues, sir. It is not just taking the baby to the OR and giving the injection. You need monitoring. You need probably a pediatrician or an anesthetist along with.
It's not such a big procedure which we are trying to make. इतना बड़ा काम नहीं है कि patient को पूरा जिए तो देना नहीं है.
No, sir.
So it's not such a big procedure that we make 2 बार OT लेना है. Compared to if you tell the parents, this thing, क्यों Vinekar?
Sir,
We can debate it. I know it's a debatable point.
our point is most of our patients are the rural patients, so they find it hard to stay in Bangalore for 2 days. But otherwise, I agree that logistically and also the disease sometimes is so bad. Waiting for 2 days, 1 day.
Malika, your opinion? Bilateral simultaneous injections in a child, ROP. Same.
Actually, I don't do ROP, so I cannot say. But I mean, if it's a very severe disease, to give GA again and again is also a problem.
It's just a
No,
mask
it's a
only.
mask,
It's
no?
a mask only.
It's only a mask.
How
So
much-
anyway, I think I always put it this way, as he said, it's a personal choice. More than scared, I think, in case I think I've seen bilateral endophthalmitis after bilateral cataract, and I asked the patient also, what's the hurry? So same here, even if it is a rush disease, and I think 2 days waiting, it's better than treating rather than develop.
2 days will not show end off. Sometimes the end off will come after 1 week, 10 days. Then you would have anyway injected bilaterally. But it won't come in 2 days. End off generally doesn't come in 2 days.
No, but either way, it's again a 2 different injections.
yeah,
so
agreed,
You
agreed.
will not have
Yeah, risk reduction is there.
Just because one eye have,
You see,
but
Yeah.
if it is the same
Yeah.
day, because of one eye, you will
Yes,
other eye
yes.
also will have.
We
Risk
all know
reduction
an
is
end
there.
off is early, late, well, that's okay.
But at least, yeah, not the same.
Separate this thing.
Given
No,
the
I know there is a society for bilateral
Yeah,
cataract.
no, I don't do it, yeah.
No, they are doing it. I don't know.
But ROP, I just thought that maybe because it's a pediatric situation to give GA again, whatever mask also. Those are the
So given the severity of the
Well,
disease,
in any
it is
case,
one
we
of
will not take it further. We know it's a controversial. Nobody will.
No,
There
but
may
we
be.
say as a preferable.
Yeah.
No?
Chal,
Like our own child, we will want to.
yeah. Thanks, Simar, for this interesting talk. And let's go ahead with. Yeah, Jasmeet, you have any point to make?
Actually, we should have waited like,
So you agree or disagree?
I think we should have waited for like 1 2 days and then proceed.
She is agreeing with us.
Okay. So let's hear now Anand Vinekar. What is new in ROP?
Thank you, sir. This is the Indian
You
perspective.
see, we all know Anand Vinekar is ROP is his passion, and he has worked so much, even with Government of India and everywhere. He has developed so much, instrumentation. Also, he has been involved. Whitefield, I know he will touch upon that, and newer classification. Also, he was a member for that task force. Anand, am I right? So he has brought laurels. We're very proud of Anand Vinekar. Let's hear him out. Yeah.
Thank you, sir.
Yes.
So as sir mentioned, the classification this time has specific importance because a lot of the contribution came from our country. And I think the significant contribution has been the understanding of this aggressive, what used to be called aggressive posterior, but now called aggressive ROP. And I'll just move to the pictures. So the images show what kind of aggressive ROP we see. And the fact that posterior was dropped was because all the way anteriorly you can see these capillary non-perfusions, which sometimes get misdiagnosed or underdiagnosed as just avascular retina. So these are the subtypes, and in fact these parts of the publication have come from Indian images. The other thing is regression and reactivation. Reactivation Dr. Simar touched upon. So I'll just talk about regression. Now regression and reactivation are two new terms that have been added to the new classification. And reactivation most particularly seen after anti-VEGF therapy, and as he mentioned, that can vary from what drug you use and what dose, and of course what the age and the gestational age or the postmenstrual age of the child is. What's important to understand here is that reactivation can be either the ridge reactivation or just plain vascular reactivation. So you don't have to wait for stage 1, 2 and 3 to develop again to decide to treat. Even if you start seeing a stage 1 or a 2, often it requires treatment because it has got reactivated after injections. Imaging devices have seen a lot of new thrusts from our country. So this is of course no longer new. It's about now 6 years old. They have an FDA CE approval. It has more than I think 100 country installations. That's the Neo. But what's new about the Neo is now they have the angio unit, which I think is very good because as we give more and more anti-VEGFs, angiography is going to play a very important role in following up these babies and deciding when to treat the reactivation. The MII RedCam is another Indian innovation. This is actually a 20D attached to a sort of phone, mobile phone kind of attachment. And similarly, the group in Ahmedabad, they also have a slightly more pliable model where you can look at the periphery, and this is handheld, and they've tried it with the healthcare workers as well. Imaging techniques, of course, we know angiography is not new, but its use in post-anti-VEGF cases is new. Now, in this case, please look at the image on the top left, and that's a very innocuous looking retina that's been injected and lasered somewhere else almost a year back, and it looks as though it's an inactive disease, but look at the angiogram below and shows you still such an active disease, and it still requires treatment. OCT is another newer imaging modality because it's a handheld device, and we are understanding now that there is macular edema in these infants which does not require treatment but needs follow-up, because some of these children who have this edema end up having lower vision as early as 6 months to 12 months, and they have to be corrected with vision stimulation. OCT angiography, if you hold the baby in a flying baby position, we are able to look at, not even though they are 6'9" or better, so they are normal visually, they're normal ophthalmoscopically, but their foveal avascular zones are not normal, and their superficial capillary plexus are not normal. We've also now been able to check the contrast of babies as early as newborn babies, or at least 1 month to 3 months. And what's important is impaired contrast also can predict their vision 3 to 6 months later, and this was one of our PG theses. Predicting ROP is very exciting. Imagine now we are able to take the tears of these babies, and let's hope the video plays. Yeah, we're able to take tears of these babies during their first screening and take it to our lab, and 20 millimeters on the regular Whatman filter paper, and we look at some of these biomarkers which are seen in the tears, and from there, and we've just published the initial work, we're able to predict which of these babies will get the disease. We are soon going to be able to follow up and tell you which of them will require treatment requiring disease. So this is very useful because right in the first screening itself, you can triage these babies saying, okay, you're more at risk, you're less at risk, and maybe your follow-up pattern will change accordingly. After the 2015 landmark judgment, which the Supreme Court laid more than 1.6 crores against, for a missing ROP and the child turning blind, we've reported some of these law judgments that out of 7 so far, 6 have gone against the pediatrician and 1 has gone against the pediatrician and the ophthalmologist. So understanding what we have learned from these cases, we've sort of summarized that into a publication. But I think understanding the fact that we must follow the current guidelines, require the consent the way it has to be taken, document it, and make sure they are followed up on time. So an error of treatment, an error of judgment is not wrong, but not following them up on time or just saying 3 weeks, 4 weeks without calling them back, or not understanding if they are transferred from one NICU to the other, making sure that the continuity of care happens to someone else, all these can amount to negligence. In the pandemic, the Indian ROP Society was the first actually in the world to come up with guidelines on how to modify screening guidelines during the pandemic, and this was followed by all the SAARC countries. We are happy to say that our country, although did see some advanced cases because of the pandemic, but most of them were prevented on time because we were able to continue screening despite that. I'm going to end with artificial intelligence and machine learning. India is making some good strides. There are groups in Pune, we've been doing some work, and in Delhi and Chandigarh as well, where we're taking these images, segmenting the vasculature, and then putting it into an AI algorithm. I just want to tell you our latest algorithm, which is now getting integrated in telemedicine platforms, is able to predict which baby, or just from an image, the system is able to tell you whether it's stage 2 or stage 3. And if this goes into the real world, you can imagine as thousands of images come out from low-cost cameras, AI will be able to do the initial triad so that only those babies who require treatment will require to be seen by the specialist. So we are at about early 90s sensitivity, which is good but not awesome, but that's work in progress. Thank you very much for the patient hearing.
Anand, I think excellent as usual. The one thing you mentioned about that 1.6 crore, I know the case.
Sir.
Was the case, was that compensation paid to the patient?
Sir, the government of Tamil Nadu paid for it because it was
Oh.
a government hospital.
Okay.
The 2 neonatologists were actually retired and they were they were professor emeritus.
Right, I know,
They were called back, but government took on the responsibility to pay it because it's government hospital.
I know.
So any other question? Time is not on our side, but one question I had was, I am aware of the tear film biomarkers which NN is doing. One patient you showed where, clinically it was looking okay, but angiography showed. So the question comes, how frequently the angio is
So
recommended?
as Simar mentioned, and we're trying to make this part of the IROC guidelines, if you are convinced that you are going to do the laser after anti-VEGF under topical anesthesia, then the surgeon's comfort would be around 4.5 to 5 kgs. After that, it's a little hard. And that usually happens between 48 and 52 weeks of postmenstrual age. So that's when we do the angiogram, document how much of persistent avascular retina there is, and then do the laser. But like in the West, if you are convinced that you can do it under GA, let's say you're a teaching hospital or you have that facility, you can go up to 55 or 60. Because after that, what happens is peripheral retinal avascular or incomplete vascularization starts telling on foveal development. So if you've not vascularized the periphery by at least 50, 55, then you will have a structural and functional disadvantage as the baby grows up. So that's roughly the line we have to draw between 48 weeks and 60 weeks.
Okay, thanks Anand. Lots of learning from this talk on ROP. So next we have Jay Seth, who also has extensively published.
PCV forms a very important cause of significant exudative maculopathy. Almost 1 in 2 of our patients, if we do an ICG or if we look for a non-ICG based diagnosis, we'll see that those NAMD patients actually turn out to be PCVs. So the previous set of Indian guidelines for the management of PCV were published way back in 2018, and they were done with a literature search only up to 2015. So, and since then many new things have evolved in the management of PCV, especially over the last 3 years. This complete absence of PDT, that is considered to be the gold standard. Hence, for these reasons, the VRSI convened the Indian PCV panel to conduct a systematic literature review and provide updated consensus recommendations for the diagnosis, treatment and follow-up schedule for PCV patients. So, as a beginner, The nomenclature of polyp has been updated to polypoidal lesions, and branching vascular network has been updated to branching neovascular network. And this is just to better characterize the neovascular nature of the disease process in these eyes. Then we come to the main gold standard that was considered till now, that is ICG. So according to the previous guidelines, it was the gold standard for diagnosis of patients with PCV, means it was mandatory for all these patients. However, according to the newer recommendations, it is mandatory only for clinical trials, but it may actually not be needed in our real world because our primary line of management has been switched to anti-VEGF monotherapy. So we don't actually need to recognize those polyps whether they are present in the subfoveal or juxtafoveal locations, or we don't need to measure the GLD because the PDT is completely out of the picture. In real world, ICG may be needed only in patients who are very poor responsive to anti-VEGF treatment, where we need to locate extrafoveal polyps that can be treated by thermal laser therapy. Similarly, even FFA is no longer recommended for the management of these patients unless we are suspecting maybe an underlying CSR where the source of the fluid is CSR itself and not the presence of polypoidal lesions in these patients. So then we come to the characteristic, the main non-ICG based diagnosis, that is OCT. So the two features that are very important include presence of the thumb-like or the sharp peak PED that can be seen, and the tomographic notch. So both of these, they signify the presence of these polypoidal lesions in the sub-RP space. The next very important OCT biomarker includes the presence of the hyporeflective lumen surrounded by a hyperreflective ring that is attached to the undersurface of the retinal pigment epithelium, and the presence of the flat irregular PED or the double layer sign that actually represents the branching neovascular network. So these were based on the 2018 guidelines. So now newer features have been defined as well as the older features have been defined better. Like the sharp peak PED has been defined as a PED having a vertical elevation of more than 70 degrees and a height to base ratio of more than 1, and the tomographic notch has been relabeled as a complex or a multilobar pigment epithelial detachment. The other features includes the presence of a thickened choroid that is age matched or matched to the axial length of the patients, a subfoveal choroidal thickness of more than 300 microns, and presence of a focal dilated Haller's vessels which is present along with the compression of the choriocapillaries. That is very important because when we see many of these patients may just have a dilated Haller vessel, but the choriocapillaries may be absolutely fine, so they may not be classified as patients having a diseased pachychoroid. Next includes looking at the on-fast OCT image of these patients and looking for these complex RPE elevations that are represented by the black in color, and there is hyperreflective BNN that can be recognized in the central part of the lower image. So that is a network that connects the multiple PEDs. And last is the fluid that is present in PCV is usually mostly subretinal rather than an intraretinal fluid. So in order to differentiate between NAMD and PCV based on OCT, there are major and minor criteria have been proposed. The major criteria include presence of a sub-RP ring-like lesion, on-fast complex RP elevation, and presence of the sharp peak PED. And the minor criteria include presence of the double layers of sign, presence of a thickened choroid with a dilated Haller's vessels, and presence of the complex or multilobar PED. So then coming to the role of OCT angio, so it does provide some amount of complementary information, especially for recognizing the network. So many studies have shown that it is more sensitive than actually ICGA in recognizing these neovascular networks. But their widespread application of OCT angio is not recommended at present because the actual detection rate of the polypoidal lesion is quite low because of the low flow, and there is a lot of scanning errors that can happen in these patients because of presence of artifacts and auto-segmentation errors. So then we come to the treatment of PCV. So if the patient is having an inactive PCV, it is better to observe. If the patient is having an active asymptomatic PCV, like the presence of a small polyp in a peripheral location or in a laser location with a 6/6 vision, we can observe those patients. And if there's an active symptomatic PCV, it has to be treated. Then it depends on the location where the polypoidal lesions are present. So based on the previous guidelines, any active subfoveal or a juxtafoveal PCV had to be treated with a full fluence PDT in combination with anti-VEGF injection. However, that is no longer recommended, and anti-VEGF monotherapy remains a definitive choice for the management of these patients. This is not just because of the unavailability of the PDT, but because PDT itself is associated with many drawbacks that includes complications such as hemorrhages, RPE, rips. And since these lesions are known for recurrence, recurrent episodes of polypoidal lesion that are treated with PDTs can worsen the choroidal ischemia as well as atrophy. And additionally, PDT may be difficult in polyps that are located in peripapillary location as well as multifocal lesions. So then coming to the choice of anti-VEGF agents. So according to the previous guidelines, ranibizumab was considered to be the preferred anti-VEGF agent based on the level of evidence. And at that time, the results of the PLANET study were not out. So at that time, aflibercept was considered only in patients who are refractory. However, if we, based on the updated literature, aflibercept remains the preferred anti-VEGF agent for the management of these eyes. This is because it has got a higher activity against VEGF and an additional activity against PGF also. And with a longer half-life, we can do a treat and extend regimen and maybe increase the patient to even Q12 or a Q16 regimen in these eyes. Brolucizumab can be considered in these patients only who are refractory to aflibercept or ranibizumab because there is very limited evidence for that, as well as because of the higher risk of intraocular inflammation that has been documented in the literature. Now, if you just look at the evidence, you know, the 24-month average study had shown that monotherapy with ranibizumab was inferior, whether in terms of visual acuity or a polyp regression rate or with the median number of injections. Whereas in the PLANET study, it showed that aflibercept was non-inferior to the rescue therapy. So if we look, although the direct comparison between these two studies is difficult, but the every study proposes ranibizumab to be given in combination with PDT, whereas PLANET study indicates aflibercept monotherapy may be sufficient enough. Now we just a minute more, sir. So if we look at there is just couple of studies that have evaluated brolucizumab in PCV, and that includes one subarm of the HAWK study. And although it showed very good outcomes, so the rate of intraocular inflammation was 50.4, and another study by Ogura had showed an inflammation rate of 19% in these PCVI. So there is very limited evidence, and the rate of inflammation is very high in these patients. And for follow-up of these patients, it can be done on serial OCT, and treating this patient with treat and extend regimen is better because it has got a better chances of visual acuity improvement as compared to the PRN regimen. And multiple literature have shown that patients who are refractory to either ranibizumab, bevacizumab or even PDT have shown very good response to aflibercept, be it in terms of polyp regression or visual acuity improvement or the need for the injections. So just to summarize, the updated guidelines are based on the evidence from the literature, and they emphasize that PCV is a multifaceted disorder that needs an individualized therapeutic strategy. So timely imaging with OCT is very critical for these patients, and a tailored treatment with anti-VEGF monotherapy, especially with longer acting agent like aflibercept, should be planned. And the current recommendations would provide a broader framework for the treating physician for the diagnosis and management of PCV for optimal outcomes. So these guidelines are freely available in the August edition of the Indian Journal of Ophthalmology in case it may interest you. Thank you.
Yeah, thank you, Jay, for this, again, a very illuminating talk. You see, believe me, everybody learns, but a couple of days back only I had one proven patient of PCV diagnosed by some doctor,
Okay.
put on biosimilar of ranibizumab.
Okay.
And obviously she was, 3 doses not responding, but aflibercept, what you rightly said, treated her nicely.
Okay.
So that's one take home. It's a underdiagnosed entity for the sake of, but one thing you have made very clear, that ICGA may not be required for definitive diagnosis, because all of us lived under this impression that ICGA is a must, but because of this lot of work being done by your group as well as by Giri and all, they show that OCT, this can in majority of these patients. But one thing you see, I for one hadn't had any bad experience with PDT. What you said, PDT is crossed, but low fluence PDT actually for me did wonders during that. Full fluence PDT, I agree, maybe have some choroidal hypo, this thing, permeability, but low fluence PDT does not.
Yes, sir, because low fluence PDT works well, especially for polyps, but the networks are usually very resistant. So if we see those
So if you have a combo of low fluence PDT plus aflibercept,
yeah.
that to me may be the most, but since we don't have it, so we have to depend only on monotherapy. Chal, thanks a lot.
Thank you.
Any Srinivas or Madam, any?
I have faced
Which are the biomarkers which are not being considered now? Because there were so many biomarkers like hyperreflective foci, 0 to 10, 10 to 21, more than 21, and majority of the authors are now telling that it is outdated and we don't do it. And the subretinal fluid over the scar is also was considered once a day not to treat it. Now with the OCTA, the perilesional halos, the loop anastomosis. So which are just 1, 2, 3, 4, which are not being considered now as a biomarker?
I think one of the few things is, the sub-RP biomarkers are the one, that are increasingly being recognized. So, I would give that benefit because that has come into picture because of the advent of brolucizumab. Because prior to the advent of brolucizumab, sub-RP level or a sub-RP fluid was never considered in our treatment plan or treatment management. So the resolution of the sub-RP fluid, that is actually meaning resolution of the PD is very important. A lot of work has been being done on CVI, the choroidal vascularity index, how the choroidal remodeling is happening. And another thing is a surgical thing is the next that can be considered for these patients because based on one of the recent papers by Flood et al, they have shown that dilated vortex vein has to be the primary pathogenesis for in the entire pachychoroid spectrum, and they have showed asymmetric vortex vein dilatation. So they are saying maybe a scleral window could be the next thing that may come up within the next 3 to 5 years that may help to halt the disease at an early stage, the entire spectrum at an early stage.
Yes.
I think we should move ahead. We have 3 more presentations. Yeah.
Thank you.
No,
Thank you.
till the time we call upon Vishal.
Yeah, but Jay has presented very nicely, and what is the conclusion is that today's anti-VEGF world is that there are only there is not any single condition where aflibercept is not recommended or is the drug of choice. Only questions comes of the cost. Now both the presidents, past president and present presidents are here. Can we make some effort that Zaltrap can be brought into the market like an Avastin, so that there is no need of using any other molecule at all in our practice, either Eylea or Zaltrap, that's all. And you don't think of anything else.
It's again a big debate, sir.
This,
I think
we will not open up this
Yeah,
Pandora
that
box,
topic is again
and neither we are agents for Bayer Group.
So I would like
no,
to.
I agree.
I request another dynamic surgeon from Jaipur, Dr. Vishal Agarwal, to please go with his talks on myopic tractional fovus cases. Over to you, Vishal.
Natarajan sir. I'll be discussing about myopic tractional foveosis. Just a brief pathological myopia, as we all know, is global elongation and a refractive error of more than -8 diopters of refractive error, or a axial length of greater than 26.5 mm. And it has a high disease burden. Myopic foveosis is about 30 to 40% of patients having more than 8 diopters of myopia. It causes excessive axial elongation, resulting in mechanical stretching and thinning of the choroid in the RP layers, leading to multiple problems like posterior staphyloma, RP atrophy, cracks, CNVM, foveosis, and finally a myopic macular hole also. So I'll be discussing the surgical aspect of myopic foveosis and few tips and pearls to manage these difficult cases. So there are 4 problems in these cases, and we'll look upon them one by one. The first is visualization. Second is PVD induction. Length of the eyeball is a major problem in these cases, and a common basic technique to get consistent results. So even a small amount of lenticular opacity in these cases causes a lot of spherical aberration. So it's always a good idea, even if there's a small amount of cataract, the patient is around 45 or 50 plus, you do a combined phaco-vitrectomy. And because the ILM is so thin and friable in these cases, absolute crisp view of the ILM is necessary, which will not be able, which is not possible through a media haze. So always you can go with the phaco-vitrectomy, so as to catch hold of the ILM in a better fashion. You can see I'm sorry about the quality because it's a projector system, but the ILM was absolutely clear in this case of a phaco-vitrectomy. PVD induction is very difficult in these cases. So there are 2 subgroup of these cases. One is 29 mm of axial length or less, and one is 30 mm or more. So this case is of a 28.5 mm axial length. As you can see, the cortical vitreous is absolutely stuck in this case. So this technique we use in our pediatric detachments also, and now we are using it routinely in myopic foveosis. So you do a core vitrectomy, you stain the vitreous with tricot, and you inject a small bubble of PFCl over the posterior pole, and you just make a small cleavage on the hyaloid face, and you just enlarge it with the blunt instrument like a light pipe, like I'm doing it here, and the whole PFCl bubble goes inside that space between the hyaloid and the retina, and you just keep injecting more, and atraumatically the hyaloid cleaves till the equator, and then the rest of the job you can do with a cutter. But that is not a good idea in high myopes more than 31 mm, because the axial length is already very high, and if you inject PFCL, it will artificially increase the axial length more. So there is no way out. You have to be persistent, patient. You have to hold the hyaloid with the forceps, cutter, a mild section repeatedly, and after a lot of patience and hard work, it will come out. But before that comes out, you cannot proceed to other procedures like staining or peeling of the ILM. So this is a very important step, and it has to be done patiently without creating any iatrogenic triggers. The third is the how to circumvent the length problem, because the instruments are not meant for such long eyes. So one is that you can use again the bracket of 30 mm or more eyes. You can use the irrigating lens. In that case, if you are using a contact wide angle, your shaft will not touch the shaft of the forceps will not touch the wide angle lens. If you are using a non-contact, it will be very vertical, and the shaft will touch the rim of the non-contact wide angle system. So irrigating lens, macular lens gives excellent resolution and magnification in these cases. Of course, in patients having 29 mm or less axial length, you can use the non-contact wide angle system. The other way around is you can make your ports more posterior, around 4.5 mm. You can remove the cannula, or you can use your left hand if you're ambidextrous, because your left hand might reach the posterior pole better than the right hand in these cases. These cases often have recurrences, and this was a recurrence of myopic tractional maculopathy. I operated around 1 month back, and this was referred to me because of incomplete hyaloid removal. You can see the whole macula is puckered, and the important point about these cases is that these membranes are not stained with trichroid very properly. So you have to use the blue stain, a trypan blue, repeated stain with trypan blue. You have to keep it a little longer, for around 30 to 40 seconds to get adequate stain. As you can see, the whole membrane was removed. And the second point is that once the ILM is visible, you have to peel it till the posterior staphyloma edge. Otherwise, the retina will not be redundant or pliable enough to get settled in the postoperative period. Even if you attach the retina, a suboptimal result like a type 2 closure can occur. So I'll just tell you the last video in which we have devised what we follow routinely in all myopic foveosis cases. This was a myopic foveosis with a macular hole, one-eyed patient, pseudophakic. I'll skip the animation. So here the PVD was already there, but still we need to confirm it again by restaining it with trimestone acetonide. Once we are sure that there is no PVD, you can see the posterior pole is quite bullous. There is a subretinal fluid, and we stain it with trypan blue, we stain it with brilliant blue multiple times to get hold of the to catch hold of the ILM. And because the posterior pole is quite bullous, we inject a small amount of PFCL just to flatten it. And here we once we catch hold of the ILM and fold it back, then there is not a problem, because now it can be seen against the poor contrast of the sclera. And we do inverted ILM flap. We peel multiple flaps of the ILM towards the hole. We don't exactly stuff it inside the hole, just give it a gentle tug. And again, the common point is that the area of the peel should be wide enough to include the curvature of the staphyloma. If that is not done, the retina will not be pliable enough to get settled, and the hole will not close in the postoperative period. After that, the whole ILM is bunched towards the hole, and the PFCL bubble is gently aspirated. So advantage of this technique is that we have avoided making a retinotomy to drain the posterior pole fluid. And if there are no additional slit breaks on the posterior pole and the macular hole was the only culprit, this fluid will be gone by the next postoperative period. Gas suffices in this case. We injected C3F8 gas with excellent results in the postoperative period. So to conclude, myopic tractional foveosis is a complex surgery with varied intraoperative surprises, and a thorough preoperative workup and planning is needed. And combined procedures, complete PVD induction with multiple staining and posterior ports that is the key to success. But the bottom line is a thorough preoperative counseling with a very clear communication about the chances of failure and late reopening of holes and modest improvement of vision should be done to the patient. Thank you so much.
Well, for wonderful videos as usual. 5 minutes are left and we have 2 more talks. Next week, call upon Shilpi to The only different thing I do, Vishal, is I still, if the detachment is outside the arcade, I will, do a small retinotomy because RP is not very healthy in these people, so it may take longer time to absorb.
Just one last question. Is ILM peeling necessary in all these cases of tractional myopic foveous cases? Recently I burnt a hand doing an ILM peel and then it opened up. It caused a large
Shilpi,
macular hole
only 4
in the
minutes are
foveous
left.
cases. So,
Yes, Shilpi. GRT 10 pearls. Video based pearls. So why is it not coming? Audio visual? Srinivas, you can ask question.
yeah. So I think Dr. Vishal, in these cases when it opens up, the macular buckles are very comes to your rescue because sometimes it's really risky. The patient was 624. I operated just 6 months back, and then he presented with a full thickness macular hole, and I tried everything, ILM transplant, everything, but he's still. No, in it. No. I peeled it, but it was in the staphyloma was there involved in that.
So Shilpi, are you ready or?
Sir, I am ready.
She's ready,
So
but the
next,
audio visual is
can
not
we have
ready.
the next person?
Burman, sir.
Dr. Burman, if you are ready. So ऑडियो विजुअल ये नहीं होना चाहिए भाई. लेफ्ट राइट लेफ्ट कैसे इंटरनेशनली हम कोशिश कर रहे हैं आप लोग नेशनल. इज नॉट एक्सेप्टेबल. नहीं टुडे इन दी मैनेजिंग कमेटी वी हैव पास्ड इफ ऑडियो ग्लिचेस होगा तो 10% फी कट हो जाएगा. कांट 5 मिनट्स तो चलना है. नेक्स्ट टीम आगे. So I'll request please rush through the videos because this all managers are after our life to finish. Yeah, start please.
Good afternoon, everyone. So thank you for the opportunity. So I will be sharing the 7 top pearls for managing a GRT.
You said 10?
For the want of time, I am
अच्छा ठीक है.
GRT is when it involves more than 3 clock hours and the edges have the tendency to roll back. So first pearl is inducing the PVD. PVD is usually present in cases of GRT. It is absent if it is a case of a trauma or some vitreoretinal degenerations. So this is a case of closed funnel RD. You need to create a space by draining the fluid, removing the membranes, and putting a PFCL bubble. So it will help in creating the space and proceeding with your surgery. So next is the base excision. In cases of GRTs, the base excision should be done at high speed and low vacuum. Just remember to remove the base at the edge, the interior flap which is there in the GRTs, because it acts as a scaffold if you leave it. And after that, also remember to do the base excision in the opposite meridian, as it may act as a contracture and lead to the recurrence. So anterior flap management, usually it is a devitalized tissue and it acts as a scaffold for the anterior loop PVR. So you need to cut it down thoroughly with the cutter. You should not leave it behind. You should depress if you feel that it is coming in the way and you are not able to remove it. And remember to do the laser if some part of the anterior flap is left behind. Now unfolding the retina. So this is a 360-degree GRT. In this you have to use the 2 instruments to unfold it, then put a PFCL bubble, and remember to put the PFCL bubble up to the edge so that the fluid is drained completely. In this case, this was a fold which was left behind even after the PFCL. So it can be unrolled by using the instrument, the closed instrument, so that it is unrolled. Now doing the laser part. So laser is to be done in 3 to 4 layers. especially at the end of the GRT, and never forget to do the laser at the end of the horns, because these are the major points from where the posterior edge slips out. So additional rows are to be given at the edge of the horns. And here we are also lasering the anterior edge of the flap. So the sixth pearl is prevention of the posterior slippage. It is avoided by not using the high and the broad buckles. PFCL is to be put at the edge of the GRT, and the SRF is to be removed meticulously by tapping it n number of times so that there should not be any pocket of the fluid. After putting the PFCL, you can do the fluid air exchange. Tap every edge of the GRT so that the fluid is removed, and then the laser is done. In this case, this was 360-degree GRT. So we are removing the fluid pocket from the every edge, every corner. And it is always not mandatory to that in cases of even 360-degree GRT that you need to do the PFCL and silicone oil exchange. Even with the fluid air exchange, you can manage the cases. And the last is, you need to tackle the concomitant pathologies like ERM. If there is a ERM, you can remove it under the PFCL. If there is a case of full thickness macular hole along with the GRTs, it should also be tackled simultaneously. It should not be left behind. The ILM peel should be done after removing the membranes. And if it is just kind of a PVR, just do, in this case, we converted it into a 360-degree retinectomy. It was a case of 180-degree, but with severe PVR, as the anterior membranes were not letting the retina to settle, so it was converted into 360-degree, then the PFCL was put, and the rest of the steps were done. So, thank you.
Thank you, Shilpi. Now we'll have, you have shown videographically very nice pearls, and most of these are practiced, by everybody. Anybody who does differently, this. So thank you, Shilpi, for your nice videos. Srinivas?
Yes, sir.
Dr. Burman will tell us about RD and PVR techniques of membrane removal. Preferably only videos.
Yeah.
Yeah. Try to omit the theoretical slides.
Okay, Manabjyoti.
So, good evening, and thank you the scientific committee for giving me the opportunity. So I'm going to speak on RD with PVR techniques of membrane removal. So the PVR and membranes are still the things that bears a lot, and they are the biggest hurdles in the successful reattachment of retinal detachment. And there should be a thorough preoperative evaluation should be there. With all the membranes should be noted before surgery, and they should be drawn properly, and a proper patient counseling should be done. There is a need for risk for resurgery may be always there. And surgical approach varies depending upon the location and type of the membrane. These membranes may have different locations like pre-retinal, post-retinal, subretinal, anterior, posterior. This may be in various shapes like a band or a star hole or a sheet of lattice sort of thing. And these membranes are really different from diabetic membranes, so one should be very careful about all these things. So I have only videos on this. So this is a case of shallow posterior retinal detachment with a sheet of membrane at the posterior pole. So a complete vitrectomy is done, and membrane is stained to see the outline of the membrane. Then gently the membrane is peeled up from the retinal surface. So mature membrane can be peeled up very easily, and immature membrane you may need to use a pick, a diamond dusted pick may be needed. So I have removed the ILM also to relieve the retinal tractions. FZIG is done and retina is settled. This is the next case. This is a bullous retinal detachment. You can see the band of retina, band of anterior membrane along with a subretinal membrane also. It's a traumatic detachment. It's a large break. So all the membranes are removed from the posterior pole in a posterior to anterior manner. So we should remove. The retina is settled with the LPFC, and ILM is being peeled, and the pre-existing break is extended, and I have gone to the posterior aspect of the retina and removed all the membranes from the posterior retinal surface. So ultimately, retina is settled with LPFC. So LPFC is being used to settle the retina, and laser is being done. So ultimately, the retina is settled. This is another case. You can see a strong subretinal band with a bullous retinal detachment. So I have done a retinotomy, and this retinotomy ideally should be slightly away from the band if band is close to the retina, and band can be picked up with a forceps, and it should be removed with a slow rotatory movement, classically described as spaghetti technique. As much as of band we can remove, it is better, and some amount of band, if it is not affecting the functional and anatomical outcome of the surgery, we can leave at the periphery. So, so the whole band is being pulled out, and some part is left at the periphery, and the retina is being settled with FGE. So multiple loads of laser and silicone oil is being used. So this is again another case. You can see a subretinal lattice sort of gliotic tissue, and with multiple bands. So in these type of cases, you may need to do multiple retinotomy, and this lattice of membrane is being removed to one retinotomy. Then I have gone again to another retinotomy, and so this another retinotomy from the disc, and this again the band is being pulled out with a rotatory movement. So again the retina is being settled with LPFC, and laser is being done.
Any more videos, Burman?
Yeah, this is almost. So this is another case. It is a blast injury from Kashmir. It is Joan. He had undergone already a reattachment surgery with recurrent detachment. You can see a very bad condition of the retina with preretinal and subretinal blood, a very taut retina with multiple scars. So vitrectomy was done, and actually a retinal detachment was induced in this case, and there is retina, multiple areas of retinal retinectomy was done, and the whole sheet of retinal subretinal gartic band was removed. So sometimes we can go subretinally also to remove the retinal bands. This is we have done a fourth retinal sclerotomy, and I have gone subretinally to hold a retinal subretinal band here without doing vitrectomy. So in this case, the retina is quite thin and the band is tough, and this type of case is actually not the right case for this type of maneuver, but still I have done it because there is it was quite posterior at a posterior pole. So always there is a risk of iatrogenic retinal break, but in posterior case of posterior membrane, this is a quite good procedure. So this is a postoperative picture of this same case. So in summary, all these cases need a proper evaluation and planning, and we should keep full armamentarium of basic equipments like the forceps, scissors should be ready, and we should do a complete vitrectomy. Our aim should be to release all friction and make retina mobile. We should use PFCL generously in all the cases, and do retinotomy and retinectomy judiciously to preserve as much of healthy retina as possible. Belt buckle and bimanual surgery may be helpful, particularly in anterior PVR cases. Belt buckle is quite useful, and always we should keep patience because these cases may need some extra time and may need to change our procedure time to time, and ultimately with patience we can get a successful outcome. Thank you. Thank you very much.
Thank you, sir. Thank you so much. I think in the interest of time, we can have the discussions with a cup of tea or coffee.
Cup of tea and coffee will be provided by Srinivas. No, thanks all the speakers. In fact, this was quite an interesting session. I only wish that we had at least 15 minutes more so that we could have discussed more. So Simar and Anand, we had a lot of learning. Then Jay article, the more you hear, the more you want to hear again. And Vishal showed wonderful videos, Shilpi showed wonderful videos, and Burman also. See, we had actually a very nice session, and I hope everybody will have some take-home points.
Yeah, and
I
thank you, Lalit sir. Natarajan sir and Dr. Manoj Saswade sir and Dr. Jasmeet for chairing this session. Thank you very much.
Group photo.
With Natarajan sleeping, we'll have one photograph.